to introduce Tara first and then Patty. Both of them work at the 𝗟𝗺𝗃𝗀𝗆 Health and Wellness Clinic. There's several locations in Pennsylvania. They work at the Lambs Gap Road in Mechanicsburg. Tara Yount is an infusion therapist. She's a registered nurse. Mother of 4. She's currently completing her nurse practitioner program at Walden University. She has spent 7 years in her prior life as a medical surgical floor hospital nurse. And she's used that experience to kind of move into a direction of healthcare that is a little more preventative in nature. She's currently working towards a certificate in I knew I would blow it. Anthroposophical medicine. Actually, I said that to myself 10 times in a row, and I got it correct every time, but certainly not here on film. It is an integrative medicine that's really rooted, its backbone is in science, but it takes into account the whole human being in terms of its method, diagnosis, and therapy. She is the lead infusion nurse at 𝗟𝗺𝗃𝗀𝗆 Health and Wellness, and she is currently working closer and closer with the low-dose immunotherapy patients, coordinating their treatment efforts with Patty Grabill. And with that, I will turn to Patty and introduce you as well. So Patty has a basic and advanced allergy training education through the American Academy of Environmental Medicine and the American Academy of Autoimmune Allergy Trainings, both the basic, intermediate, and advanced curriculum. In 2006, she started her practical study background with LDA, Low-Dose Antigen. And that therapy was really coursework that was written and really started putting on the map by Dr. Schrader. In 2008, she actually worked for the first medical practice in Pennsylvania that was offering LDA to their patients. So she's got a long 15, 16-year background, which is pretty long in the LDI, LDA continuum. In 2012, she advanced her continuing education through the American Academy of Environmental Medicine, and she continues her ongoing education and continuing education with the LDA. What I learned as I was helping to put this presentation together was LDA kind of started the protocol to take this treatment program and put it on the healthcare map. It evolved to LDI. And with low-dose immunotherapy, it started getting a whole new body of doctors and medicine and treatment protocol and kind of outcomes and evidence-based outcomes. And then that slowly evolved to what really spoke to me, that the practice that they really do largely now, which I'm sure they'll get into, 𝗟𝘆𝗺𝗺𝗃, Lyme, yeast, and parasites. So having a no invasive type of treatment option to start working at some of the drains of the immune system is really what their claim to fame is, or the claim to fame. One last thing I'm going to say before I turn it over, and this is so true, that when we have a presenter or we are showcasing a treatment protocol, always I get response from people that say, it saved my life. I am symptom free. If it wasn't for this, I could never have conducted the level of health that I have now. And I also get communication from people that say, didn't work for me. And that is the dilemma. That is really the spectrum of results. And we say this all the time. Lyme disease is so unique. It is so personal. It's very, very individualized. And when I say Lyme disease, please hear, I also mean all the co-infections, all the 𝗟𝗶𝘀𝗃, the Bartonella, the Anaplasmosis, the 𝗟𝗆𝗺𝗃, the Rocky Mountain Spot, that whole hornet's nest of pathogens that deer ticks transmit, that's what I mean by Lyme disease. Some people get symptom-free, some people struggle for decades. So I don't know how this is going to work for you as you're watching it, but with that backdrop, Tara, Patty, I'd like to turn it over to you. Who would like to start us off?
I'll start us off, Eric.
Okay, thank you.
Thank you so much for that nice introduction. And it really segues quite well into the beginning. Are we going to put the PowerPoint up?
Yep, I should be doing it right now.
Okay.
Can you see it?
Do you want me to wait a minute or do you want me to keep going?
Oh my. We are now experiencing one of my worst fears. Come to realize. Okay, so.
I told you we are a very forgiving audience. We have so much forgiveness for anyone that's in our community. You have nothing to worry about.
This was one of my Dante's Inferno. This is one of my levels. Okay, so I'm not sure what I'm doing wrong here, that it's not sharing. Okay, here we go. I got it. I believe.
Get blast off.
Yeah. Okay. Whew.
All right.
Can you see it?
Yes, I can. Excellent. Excellent. So what Eric said is going to give us a perfect segue into my first topic here. We're going to talk about low-dose immunotherapy for Lyme disease. And we're going to start with a little bit of evolution because I really feel strongly that a lot of people have never heard of it before, or if they have heard of it, they're not really sure of the origin. So basically, Eric is absolutely right. LDI did evolve from LDA, but also LDA evolved from EPD. So I'm going to start with EPD, and I'm going to start in Great Britain in the 1960s, and I'm going to start with Dr. Leonard McEwen, who developed EPD, which stands for enzyme potentiated desensitization. Don't worry, you don't have to remember that because as we work through this, we're going to be talking about LDI. But I do think it's important to talk about where it started. So he was doing some research for nasal polyps, which are usually allergic based. And in a long story short, he developed EPD. And that is actually the standard of care in Europe even today. EPD is still used in Europe today. And I know that for a fact because at times we have military patients or other patients who are in the States and then for whatever reason are going to be going to Europe and they need to continue their care. So you can still find it as standard of care in Europe. But on or around 1990, it did migrate to the United States. And there's a doctor in Santa Fe, New Mexico named Dr. William Schrader. You heard Eric mention him. And he's an allergist. And he actually brought the treatment into his practice and also began teaching it to other doctors. So at that point, according to my research, there was probably about 50 doctors in the United States who were doing, and at that time, it was still EPD. Dr. Schrader started the American EPD Society between 1990 and 1993. And that enabled him for research. And he published his first research study in 1993. There is still some research studies between EPD and LDA on his website. So for anybody who's interested in that, we can talk about that during the questions. So then from 1993 to 2002, the treatment was being used successfully, but there were some problems with the FDA because the serum was coming in from Great Britain. They no longer wanted the serum to come in from Great Britain. And the problem was that in order to get the serum passed by the FDA, it was actually quite costly. And I think that maybe a lot of you know that getting a medication passed by the FDA is not an inexpensive thing to do. So rather than do that, Dr. Schrader actually took it upon himself, and the serum was no longer being imported into the USA. The patients who were receiving it had to either drive to Canada or wait for Dr. Schrader, who developed LDA. So he took EPD and he kind of ironed out what kinks he thought were in it, and maybe added some things that were more common in the United States as far as allergens go than in Great Britain. I don't think there was a great deal of difference, but according to him, there was some modifications. And then he rolled that out about 2002. And back then that was being produced in a compounding facility, and it's still being produced in a compounding facility today. In 2007, I had about 11 years under my belt as an allergy technician. I was not using LDA. We were not using it in the practice that I worked in. However, we were using traditional desensitization and neutralization, which I thought fell short for some of the patients that I saw who had mold allergy and who were very, very, very sick, some of them debilitated. So I was online and I was researching, and I was very sure that I was going to find something appropriate. And lo and behold, I came upon LDA. And by 2008, it was being done in the practice that I was working in. And that was very exciting and very rewarding for me. 2015, by this time, Dr. Schrader was probably starting to look at retirement age. And although he was still a practicing physician, I believe that he felt, actually, he told me he needed a protege. And that protege came along around that time, and that was Dr. Ty Vincent, who became the producer of LDI. So for a period of a few years, Dr. Schrader and Dr. Vincent worked together. And however, it was Dr. Vincent who developed the Lyme antigen. The Lyme antigen was not being used in the office that I worked in, but in the circles of LDA, I was hearing a lot about it, and I was actually hearing a lot of very positive things about it, but I did not have a chance to actually utilize it until 2019 when I came to 𝗟𝗺𝗃 Health and Wellness. And then just prior to that, Dr. Vincent decided that geographically he did not live in the same area as Dr. Schrader, and he was going to be moving to Hawaii, where he had his license there and in Alaska, actually. And at that point, he decided to open Global Immunotherapy, which is the company that produces LDI. And they now have all of the external antigens, and by that I would mean foods, environmental, that would be animal danders, mold, pollen, dust, as well as treating chemical sensitivities. Of course, he had his Lyme antigen. He also had several autoimmune antigens that were being used, and a scattering of a few other ones for latex allergy, poison ivy, poison oak, just to mention a few. So that gives you an idea of that timeline. It's just going into a little bit more detail. And just important to note that today we are still using both LDA and LDI in the practice where I work, which I think is valuable. I think they're both valuable because there are some patients who did LDA for years and are still doing maintenance, which I'll talk about later. So there'd be no real reason for them to switch over to LDI. If they're doing well, we would not switch them over. But new patients coming in, we are using LDI. Okay, so from here, we're going to go into a bit of terminology, and Tara's going to take that. And there's no test later on, so you don't have to remember this.
Well, first and foremost, thank you for the introduction. That was lovely. And for saying anthroposophical, you get a point for that. And I want to just remind everybody, Patty's really the expert in LDA and LDI, and she was kind enough to kind of bring me up alongside of her as the novice. So I'm thankful for that and thankful for learning this. And as you'll hear later, I actually have used LYP myself with positive results. So the first term that you're going to hear is immunotherapy, which is basically what we do when we give you the antigen. We engage the immune system to fight the disease. In this case, it's Lyme disease. So low-dose immunotherapy is LDI, and under that, we use the LYP. Antigen is the substance which induces an immune response, ending in antibodies. So the hope is that we give you an antigen, in this case, LYP, and basically we desensitize your body to becoming reactive to it. And you produce antibodies that you no longer have to have your immune system meet it anew each time. LYP is the word you've already heard a lot, and that's the antigen comprised of Lyme yeast and parasites. And Dr. Vincent put those three together because they really seem to have a synergistic effect, and they seem to be most commonly, they do come together. So it just works really well. And dose titration is the increasing the strength of the antigen. And so when you first come to see Patty or myself, we have a spectrum on which we work, and it's 30C to 4C. And so like the most important thing to know about that, and Patty will go into this a little bit more, is that 30C is actually the weakest dose and 4C is the strongest. And so we start you somewhere on that spectrum, and there's a lot of things involved in deciding that number. And some of it's intuition, which Patty is really good at, and a lot of our providers are actually pretty good at. So we start you at the dose and we see how you respond. And if you have a certain response, we decide whether or not we move forward or stay at where we're at. One of the important things to know about that is that if we do engage a response that sort of decides good or bad if we move forward, we can only actually stimulate the T cells once every 7 weeks. And the T cells are really the white blood cells that are responsible for creating an immune response in your body. Flare is a worsening of symptoms. And this is the one that as an infusion nurse, and I also give ozone, everybody's most concerned about. And I think it's important to think of the flare as not necessarily a failure. And Patty will talk to this, speak to this also, because it really is important information that tells us we've engaged your immune system, and maybe we didn't get the feeling better results that we wanted immediately, but we know that we have, we're barking up the right tree. So it's not a failure. It is a possibility, and we have a lot of ways that we can help you mitigate the effects of a flare that we'll go into later. The effective dose is the strength that most effectively improves symptoms. And like I said, that can only be given every 7 weeks. And I think it's important also to note that this is a journey. And as Eric said, 2 people can sit in the same room and have completely different responses to the same treatment. And I have my own story to speak to with that. And I like to remind people that, you know, my situation and my response won't necessarily be theirs. But once we find your effective dose, you're having an improvement in symptoms. So if you're having joint pain, brain fog, whatever that may be, you're seeing that diminish. And then once we find that, we can actually help you maintain your wellness with booster doses. So if we gave you 14C and that's your effective dose, we would give you 15 as a booster, which is actually weaker than the 14. And you can use that in between effective doses, which means if you're starting to have symptoms again, or you're starting to just feel yourself slide back a little bit, you can self-administer the booster dose. We give you some to take home, and it actually is pretty effective at pulling you out of those symptoms. And that's anything else you want to add, Patty?
No, that's great, Tara. Thank you. Thank you. So next, we're going to talk about how to proceed with LDA treatment. So the most logical thing to start with would be administration. So how do you administer the dose? All of LDI is actually administered sublingual, and that means that it is dropped under your tongue. So what we do is we use a small syringe to pull it up from a vial. And the reason why we do that is because it's a very small dose and it needs to be measured precisely. So it is important that a syringe is used. After that, we clip the needle off. And if we're dosing it there in the office, then we would go ahead and we would squirt it under your tongue. And that would then be given into the sublingual glands and into the lymphatic system. Was it always done that way? It was not. Historically, EPD and LDA were always done by intradermal injection, which is the type of injection that you would get when you, if you've ever had a TB test and they make a little wheel under your skin, that would be an intradermal injection. So it was always done that way for EPD and for LDA up until, as far as I knew, about 2010, where there started to be some chatter about sublingual in the LDA circles. And personally and professionally, I was very excited about that because at that time, I was working in family practice. And I had probably 40% of my patients that I saw for LDA were children. When I went to the waiting room to get them, they would run to the corner or hide under their chair or bury themselves in their parents' arms, anything but wanting to come with me. So when I heard about sublingual treatment, I thought this is wonderful that we could possibly treat the kids this way without losing any of the improvement. And most of the kids that I saw, that 40% was pretty much comprised of eczema, asthma, and seasonal allergies like hay fever. So we did it and it worked and we never saw any regression. And of course, the next thought process after that was, well, if it works for children, why wouldn't it work for adults? We knew that logically there was no reason why it wouldn't, but we did that back then selectively. So if a patient was coming into the office and they were adults, they were getting an injection. If there was some reason, maybe they retired and moved to Florida and we could ship them their doses, then we did sublingual. However, when Dr. Vincent took over, his real philosophy is that tolerance is best achieved orally versus injection. So all of LDA is produced for sublingual only. That's an important distinction to make. And I'm gonna just borrow Dr. Vincent's explanation for that. And his explanation is that when you have a baby who has a growing immune system, what do they do but put everything in their mouth? So it is another form of oral tolerance, and that's what we're using with LDI across the board. And I also feel that it reaches more people. There are people who are needle phobic. There are people who just don't want to do shots. And then there are children, you know, like I had in family practice. And so bottom line is you can reach more people. Okay, so next, how is that dose chosen? We know how the dose is given. How is it chosen? So Tara got into this a little bit with the 30C to 4C or 4C to 30C. You can look at it either way, as long as you remember that 4C is always going to be the strongest and 30C is always going to be the weakest. So it's exactly the opposite or counterintuitive. And if you're like me and you think backwards a lot, then it works very, very well. So you can actually take 30C to 4C and break it down into about 3 areas. And we can take that lower area, possibly from 30C to 20C, and say that that might be a good area for a more severe patient, and then take 20C to maybe 12C for a moderate patient, and then anything from 12C up to 4C for a patient who's much stronger. We actually do not start patients up in that stronger area very often. It's much more common for them to be started in the lower area or in the medium area. So LYP on the tray that we keep it on is mixed from 4C to 30C, and I'm repeating myself, but again, I just want to stress that the 4C would be the stronger area, the 30C would be the weaker area. We're going to talk about that more as we move on. Okay, so then we're going to talk about next the antigens that are in the dose. So there are very trace amounts of antigens in every dose, and LYP is no exception whatsoever. So the most common question is, why are there trace amounts of antigens? And Tara talked about what are antigens. In this particular case, we know that we're dealing with the Lyme infections, the co-infections, the yeast species, and the parasites. We're dealing with very trace amounts, and we're doing that because the job of LDI is to retrain the immune system through the T cells. And T cells are just a part of your immune system that communicate in some way. And when you have a chronic illness such as Lyme, or such as food sensitivity, chemical sensitivity, the T cells are not performing optimally. So if we can retrain those T cells, and through that, we can provide tolerance to whatever we're telling it to build tolerance to. In this case, we need the trace amounts in there of Lyme, yeast, and parasites, so we can build tolerance to those items. So I'm going to throw a little analogy in there because I think that that concept is kind of difficult to understand. If we took 10 people and we gave every single one of them Lyme disease, what we know is that not everyone would get sick, right? We know that. We know that some people can be infected with Lyme disease and never succumb to the symptoms. So why is that? It's their immune system response, right? So their T cells are performing optimally. Their T cells have tolerance. So that gives us the contrast. And what we want to do is we want to change you into one of those people. So let's talk for a minute math, because a common question that I get and that Tara gets as well is, well, how trace are these amounts? If we take 5C to 6C, so this is up into the stronger area, it's equal to about 10 to the negative 12 power. If you're a math mind, that's going to tell you that these are very, very trace amounts. If you're dealing with food, these are not amounts that anyone would ever ingest, even if they were on the tip of a needle. These are tiny, tiny, tiny amounts. Again, and we need those in there to act as identifiers for the T cells, so the T cells know what to build tolerance to. If they weren't in there, it would not work. Okay, so the next slide is going to talk about the effective dose. So the initial phase is finding the effective dose. So at this point, we're working with an individual patient, and we want to find the dose that's going to improve their symptoms. We have a lot of doses. We have from 30C to 4C. And in the beginning, we're going to work with only whole numbers. As we move along, I'm going to explain about having half doses, but we'll get into that in just a moment. So I call this next phase the investigative phase. And that's because we're really setting aside some time to try some different doses in a methodical way and see what might work. So it is very much an experiment. When we do these doses at this point, there's actually two ways that they can be done, and they're all done sublingual, but they can be administered in the office where I would draw the dose up and I would administer the dose, or the doses sometimes can be sent to the patient and the patient actually administers that dose themselves. We always do a telephone consultation before that so that they're not going into that without knowing what to do, but it's actually pretty simple. So at some point we teach self-administration of that sublingual dose. Okay, so in titrating the strengths from 30 to 4C, within that investigative stage, we are always across the board going to work from weak to strong, right? It wouldn't make sense for us to start at a strong dose. It would make more sense to start at a weak dose and then gradually increase, which is where we get that term titration. So we work from weak to strong also because we want to try to avoid a flare if at all possible. And then we work in batches of 5. So that can be any number, but it will be all the numbers that follow it going in the opposite direction, because again, in allergy and immunotherapy, that concept of strength is somewhat counterintuitive. So we work in batches of 5, and as you can see in the example there, we use 25 through 21 as an example. So if I were going to work with a patient who possibly did their consultation on the phone, and then I was going to be sending them the doses, this would be a good example of 5 doses that I would be sending them, and then I would be very explicit that they would be starting with 25. A lot of patients will project into the future and worry about, okay, well, if I'm going to do 25, what do I do with 24, 23, 22, and 21? And that's a very valid question. And the answer is that you're not going to do anything with it until after you report your response to either Tara or I, and then we are then going to give you instruction back on what to do next. So there is never a case of a patient just going off and doing doses arbitrarily. We always do doses for a specific reason. So what would be the reasons and what would be the responses? What we're actually looking for when you take a dose or when I give you a dose is, do you feel the same? No change at all? Do you feel better? Or do you feel worse? So that's the kind of response that we're looking for. And in a case of a patient feeling the same, then we would instruct them then to move on to dose 24 or whatever dose would be the next strongest one. Using our example, it would be 24. The period of time that we ask you to wait is about 7 to 10 days. Most patients report back in a week just because I think it works well for their schedule. And the other thing that we look for is a report of better. So what happens when a patient says, I feel better? My symptoms have improved. What do I do next? What Tara and I will tell them is that you wait, because it wouldn't make sense then, would it, to go to a stronger dose? That wouldn't make sense because they're feeling better where they're at. Wouldn't make sense to go to a weaker dose because they're feeling better where they're at. So in a case of better, we ask you to wait and see how long that lasts. Is it going to last for another day, 2 more days, 3 more days, another couple weeks? All of that is very important and vital information for Tara and I, because it helps to determine, it helps us to determine how close we are to that effective dose. If in fact you do flare and you do feel worse, then that is another scenario. And we're going to talk about how to treat a flare on the next slide. However, I always tell a patient that if you believe that you are having a flare, don't worry about telling me. You have your instruction on how to treat it. Begin to treat your flare and then come back and tell me. And then we'll talk, and then we'll see. Because one of the things that we always have to determine when a patient reports a flare is, are we absolutely certain that it's a flare? And there's a couple reasons for that. And one of the reasons is when there's a flare, we have to wait 7 weeks. We've stimulated T cells. We can't stimulate T cells again for 7 weeks. So we don't want to put any more antigen into the patient's immune system. That's not the right way to go. So we want to be sure that if we are going to wait a whole 7 weeks, that it truly is a flare. What could it be if it's not a flare? Sometimes it can be, patients have anxiety about going through this treatment because it is connecting, with symptoms that they've had or that they do have. So that sometimes can come into play. And also, we don't want to call a bad day a flare. Most patients that I see have good days and bad days. So if they are having a bad day, we want to make sure that we're not going to call that a flare. And then half doses are used as indicated. And since my mind is still thinking about a flare, I'm going to come back to half doses in just a minute. So on the next slide, flares do happen, but as Tara said, and it's absolutely true, it's proof that we're barking up the right tree. If it is a flare, we do have to wait 7 weeks. And my thought process, and many times my remark to a patient, is that if we can make it worse, we can make it better with a weaker strength. So we might have to wait 7 weeks, and maybe we can work on something else during that time, but we do have to wait. Now we want to talk about what we do for a flare, because if I don't, that's going to be the very first question that we get from the people listening tonight. So we treat a flare with bicarb, and we treat it with oral bicarb. How do we make bicarb? I can guarantee that you all have it in your kitchen cabinet. We make bicarb most easily and cheaply with Arm & Hammer baking soda. So a half a teaspoon of baking soda mixed in with about 3 ounces of water. The amount of water doesn't really matter. Will begin to neutralize a flare. Not one dose. We'll need to repeat that every half an hour to every hour, maybe every 2 hours to 3 hours, depending on the intensity of the flare, depending also on how quickly the symptoms return once you take a dose of the bicarb. And that is a very common comment that a patient will make, that they take a dose of bicarb and they feel some of the symptoms neutralizing or going away, and then in a certain period of time it comes back. And usually when you're treating a flare, you'll see a pattern emerge, and you'll actually know, okay, I need to take a dose of this every hour. And there's nothing wrong with doing that. There are 2 other products besides besides baking soda that we can only use. So I already gave that one away. 𝗟𝗆 Gold, GOLD, is a product that we can use that would be sodium bicarbonate and potassium bicarbonate, whereas the baking soda is sodium bicarbonate. There's a third product that we can use called Tri-Salts, which is made by Ecological Formulas, which is a powder but does not contain any sodium. It is bicarbonates and carbonates of calcium, magnesium, and potassium, has a more mineral taste versus the salty taste, but it works the same way. The dose is the same, a half a dose mixed in with about 3 ounces of water. Again, the amount of water doesn't matter. The most important thing with a flare is frequency, staying on top of it, not stopping it just because you think that you might be better, but continuing it and making sure that you're completely better before you completely stop. And in most cases, patients I see will neutralize their flare in 1 to 2 days. So that's not too bad. The next is sort of a personal thing that I say to patients as we move through the process that I think is very appropriate. It's the 3 Ps: patience, persistence, and perseverance. So we've talked now for 25 to 30 minutes, and we see that there's a lot of detail. We see that there's a lot involved here. So it would follow that patience, persistence, and perseverance would be needed. And between Tara and I, you won't find more support from your providers, and you won't find more patients and more persistence and more perseverance either. Tara and I both feel very strongly about the treatment. We've seen people get better. And so we just ask for that same thing from you, just the 3 Ps. And then, okay, so what do we do next? So I'm going to take that from the point of finding an effective dose. We've been going through the investigative phase. We found a dose that improves symptoms. For right now, we're going to call that the effective dose. And we're going to introduce something called booster doses. So I'm going to jump around a little bit on this slide. If we have a dose that improves the symptoms, just like Tara said in the terminology slide, we can use booster doses to actually boost the effectiveness of that effective dose to make it last the whole 7 weeks, because otherwise it's not going to, most likely, it's not going to last the entire 7 weeks. So that's the importance of booster doses. Reproducing the response is something that I feel is vitally important during the investigative phase. And what it means is that 7 weeks after you take the dose that turned out to be your effective dose, we're going to reproduce that response, hopefully. We want to make sure that that response you had initially was not an anomaly. We want to reproduce it, and we want to make sure that we see the same response and that we get the same response from the booster doses as well. Once we can encapsulate that and reproduce it, then I feel comfortable about moving on with the patient. And we will continue dosing with that effective dose every 7 to 8 weeks or every 2 months, whichever way you want to look at it. And we want you to be consistent and persistent. And believe it or not, consistency is very important when it comes to this. And if you do your whole first year at 7 weeks, you'll actually get 1 more dose in a year's time. If you do it every 8 weeks, that's every 2 months. So 2 times 6, you know, you're going to get about 6 doses in a year. But if you do every 7 weeks, approximately, you can actually get a 7th dose in about a year's time. And that's a giant leap in LDA terms. So consistency is vital. Booster doses are a huge help. And we're going to move on to long-range expectations next, because this is a very common question that a patient will ask. Do I have to do this forever? And the answer is no. But we want to continue to do it as long as you're feeling better. We don't want to just stop. So how do we do that? So the most common scenario that I see is about 1.5 to 2 years of every 7 to 8 weeks. And at the point where we get the appropriate response, that means we're ready to go to 3 months from 2 months, right? So what's the appropriate response? As you move through this, you'll find that we rely heavily on the things that you tell us, that you'll find that Tara and I are good listeners, and that we remember the things that you tell us. And one of the things that patients say when they're ready to move on to 3 months is they'll come in and say, well, I'm due for a dose today, but I almost don't even feel like I need it. And that's where I jump up and down, because that's where I know that we can safely move on to probably 3 months. And to be honest, that is a negotiated time frame. Many patients will say to me, wow, I don't know if I'm ready to do that. Can I do 10 weeks instead? Can I do a shorter period of time? And the answer is absolutely. As long as we always stay at least 7 weeks apart, we can absolutely do almost any time frame that you would like to do, with the exception of not stretching out too far, too fast, because then we'll lose our momentum. As we move along, we can go from 3 months to 4 months. We can go from 5 months to 6 months. And that's a time when patients are very happy. They're feeling like they've reached the light at the end of the tunnel. And so where does it go from there? Once we get to 6 months, we have to remember that that's only 2 doses a year. And if that's what we have to do for maintenance, it's really very little to ask in relation to having 75 to 100% improvement. So every 2 months is actually a very common maintenance dose. I see people a lot every 6 months is a very common maintenance dose. And I see people a lot who are at the point of only having to get 2 doses a year. So it's a very fulfilling time as well, because you know you've stayed the course, and you know you've kind of reached the part where you really reap all the benefits. Some people can go beyond 6 months. They can do 7, 8, 9, 10 months. There's really no limitations. Some people can go beyond a year. I've had a few people who didn't need a dose for a couple years. But the more common is to need some kind of a maintenance dose on a regular basis. And I believe it also just keeps you optimum. So also, I just want to mention, because this is something that I touched on earlier when I was talking about a flare, and I said that we'd have to wait 7 weeks, and there's some things that we can work on in between. A lot of patients need food treatment, so they have food allergies, and some of that comes from the fact that the Lyme has really inundated the immune system, and they have a laundry list of foods that they can't eat, or they have a short list of foods that they can eat. So some patients need to be treated for foods, and we can do that with LDI. Some patients have environmental allergies. So again, just touching on the components there would be animal danders, mold, pollen, and indoor things like dust and mites. Also, our environmental antigen also has insects in it. So it helps people who have a very strong histamine response to things like mosquito bites. So those are other things that can be added, and actually they can be worked on during the time that we have to wait in between a flare. If that does occur, we have 7 weeks. So why not make use of it? Also, LDI employs a whole host of autoimmune antigens, just to name a few: ulcerative colitis, Crohn's disease, Hashimoto's, just to name a few. I actually have a patient who's using 𝗟𝗚𝗃, and we're also treating her for rheumatoid arthritis with the RA antigen in LDI. So that's also another area that we can treat. And then I think we're on our last slide. And it's simply just a phrase, 6 words that I hear and are music to my ears. And that is enjoy a new lease on life. And many times I use this phrase because it's something that people say to me when they get to a point where they're no longer waiting for the other shoe to drop, where the good days have outnumbered the bad days. They tell me that they have a new lease on life. And I just think that it is a goal to set. It is something that we have to think about when we are challenged with health ailments. And so I wanted to add that at the very end. I want to thank everybody for their attendance, and we can proceed with questions.
All right, thank you very much. Yeah, we're starting to get a few questions coming in. If anybody has questions, please use the Q&A feature in Zoom, or you can just leave comments in Facebook. The first question would be, you guys operate in the Harrisburg area. If somebody wanted to find an LDI practitioner in their area, maybe in Pittsburgh, maybe in the Philadelphia area, how would they go about finding someone?
Well, I can tell you that we actually have a lot of patients who travel from several hours away, so that it would not be impossible with today's technology. It would not be impossible from a patient anywhere who had computer access, who had Wi-Fi access, to be able to become a patient and to be treated with LDI. Now, I believe as far as seeing one of the providers, that there are some restrictions for out of state where the patient might have to be seen once annually. That's something that, you know, we could check in with the office on. But as far as that goes, there really isn't a problem. The way that I explained the way the doses are administered. There's really no problem with self-administration. There's no problem with reporting doses. That can also be done with portal messaging or emailing. But if we truly had, a case where somebody wanted to find someone closer to them, then what I would do is I would either have you reach out to Global Immunotherapy, or I would reach out to Global Immunotherapy, and they have like a state-by-state listing. For whatever reason, they don't publish it. LDA publishes their state-by-state listing, which makes it a lot easier to refer patients. So I can tell you that there are a lot of doctors available in most states. So we would be able to help you one way or another.
Okay, thank you. Someone is asking about the cost, the approximate cost to start the program and the maintenance cost.
Yes. So that's going to be different at different practices. So I can't quote you any kind of pricing from other practices because it's not streamlined in any way. I think a lot of that depends on whether the actual physician administers the LDI or whether they have a technician or a nurse or a medical assistant that works under them. So there would be a little bit of variety as far as pricing goes. At our office, for the investigative phase, you would be looking at $240, and that would cover our time being spent together for however long it takes to find the effective dose, to identify the booster dose, and then to reproduce the response the second time. So in most cases, and I really actually should have mentioned that, in most cases that investigative phase lasts about 4 months, but not always. Sometimes it's shorter than that. So you could expect $240 for approximately 4 months. And then once you go on an every 2-month cycle with your treatment, it would be $240 every 2 months.
Okay, very good. Someone is asking about, ooh, where's that coming from? What has been the, what's the success rate and how long potentially before you start feeling better?
Yeah, that's a good question. Typically, success rate runs right around 80%. And a big, huge part of that is going to be compliance. So it's going to be accessing that patient's persistence and perseverance that I was talking about in the last few slides there. That's very important. That's a very important part of it, is sticking with it, not giving up, because honestly, I have some patients who start rather weak and end up at a fairly strong amount. So we'd be talking about up there from maybe 6 to 𝗟𝗺𝗃. And that might not be able to be anticipated, and it is going to take a while to get there. So what was the second part to that question? I'm sorry.
Where is that coming
How long
from?
till you feel well?
Yeah, how long do you feel better? Yeah.
As soon as you find that effective dose. That answer is hard to say, because we're always going to be starting people in different areas of strength depending on their personality. So it would be very difficult for me to say how long it takes. Some people get it on the very first one. Their very first dose that they take ends up being their effective dose. And I think that Tara could speak to that, because that was her case. Tara, speak to that, because that's.
Well, and
We
I like to
We have
tell you
requested to hear Tara's success story, so maybe she can tell us.
so that's unusual. I like to tell people that, but literally as soon as Patty walked in the door with the antigen, I think I was on her. No sooner did she set down her bag that I wanted to try OIP, because I was just tired of feeling tired, and everybody that has Lyme knows about how that gets to be. And I had done another course of antibiotics, and I actually am lucky to respond well to 𝗟𝗆𝗄𝗗𝗃, but it's not necessarily good for your gut or your body to be on that for extended periods of time. And so I think one thing that's important to know is that Dr. Vincent does have a range of doses that's in his years of practice seem to be a good area to start. And I think there's also a little bit of intuition. And when Patty spoke to depending on how a person feels, that is true, because there's some people that go at this with trepidation. And I think that's a normal response because you're afraid of feeling worse. And there's other people that are kind of like, just give it to me. And that's not right or wrong either, because you could potentially flare yourself. But I trusted Patty's intuition and our other provider, Amy, and they hit it right on the spot. And so I took it. And I had a pretty rapid and immediate improvement in symptoms. And I don't even think that we actually titrated too much, maybe one or two doses. And then I started to feel it wear off. And so we tried some boosters and they were effective, which also told us that the effective dose was working. And since then, I've taken the effective dose pretty much every 7 weeks, and I'm using boosters once in a while. I forget that I have those at my disposal, and Patty will gently remind me by leaving them on my desk, or if I complain to her about not feeling well, she asks me if I've taken a booster lately. And I will say, that's not the case. And sometimes I'm hesitant to tell people because I don't want people to lose hope if they don't have an immediate response. It's not going to be that way for everybody, and we see that with infusions, and we see that with ozone, and we see that with everything that we do. That we're often doing a few different things, waiting longer times, for other people to have a positive response. But I can also say, in the short amount of time that I've been doing this with Patty, that I have seen a lot of people, and I've even witnessed the few people that have had a life-changing experience in there. One thing that I think about, especially in our patient population, is there's a lot of afraid to be hopeful. So sometimes I feel like people kind of dampen their response or are afraid to tell you if they're feeling good, because the insidious nature of Lyme is that it pops its head in and out of your life. And so in not wanting to speak to wellness, they really kind of temper their response, but I have seen people get well on this.
Okay, thank you for that. We have two people asking about other conditions. Can it be used to treat? One person is asking about Crohn's and another person is asking about osteoarthritis.
Yes, Tara, do you want to take those?
No, you can.
Okay. It's a yes to both of them. For osteoarthritis, we would actually use the collagen antigen. And then for Crohn's disease, there's a couple different ones that can actually work. I've actually worked with that longer than I've worked with the collagen, but have had success with both.
Okay, very good.
And if you don't mind me, I think one thing that's important to know when we use the LYP, and maybe Patty knows the exact number of Lyme parasites that are included in the LYP. So that's the benefit of LDI in itself, is that we're not targeting just one thing. When you get the serum, you're getting like a whole host of things. So like she spoke to with the environmental and chemical. And so you're really creating a response to many different things. And that's the case with Lyme, where it really covers such a broad spectrum of all the potential Lyme infections that it's nice in that sense, because you're not kind of trying to find a particular infection to target and eradicate.
Someone is asking about LYP. Are there new advancements being made in LYP, or is it settled on how it works at this point?
I think what we have to remember is that LDI is the treatment and that LYP is just one of the antigens. it has many components, but it's just one of the antigens. So if we take LDI and we talk about all the antigens, then we talk about the food antigen, we talk about the chemical antigen, the environmental antigen. LYP is just another antigen. So as far as more advancements, I'm not sure exactly what they would mean, like as far as adding more things to it. Not that I know of. My last conference with Global Immunotherapy was actually May of last year. So we'll be doing another one this year. And LYP was actually developed, if you remember, like Tara was talking about during the terminology, that it used to just be a Lyme antigen, and yeast was separate and parasites were separate. But what he found was that he was using the yeast and the parasites for Lyme patients so much. And we have to remember now that this would be time consuming. It would be time consuming if it takes us 2 to 4 months to find an effective dose for just the Lyme, and then another 2 to 4 months for just the yeast, and another 2 to 4 months for the parasites. We could be talking about a long period of time before we could get someone well. So the antigen, the 3 antigens were developed into one, LYP. And I can tell you that when I was at that conference with 2 of our providers, that would be Amy, our nurse practitioner, and Dr. Regina Smith, when they heard that LYP was Lyme yeast and parasites, they were very excited about bringing that antigen home, because all we had at the time was just the Lyme antigen, the yeast by itself, and the parasites. They were very excited about it. And now we see why. We see why, because we can kind of, I don't always like this, but we can kind of kill 3 birds with 1 stone, so to speak. I don't always like that analogy, but it works for this particular case.
You use the word flare. Are you using the word flare similar to Herxheimer reaction?
I'll let Tara take that.
Well, I think we talk about this a couple times, because I know Herx is the one thing everybody's trying to avoid. And I think it's important to note the difference between engaging the immune system, which is what we're hoping to do with this antigen, versus herxing, which is just the return of symptoms, you know, maybe without any stimulus, or with antibiotic use, or with a die-off, or with, you know, some other reason for that. But with LYP, we're engaging the immune system. So flare is just your immune system kind of responding to that engagement. Did that make sense, Patty?
Absolutely. I get that question with almost every patient, and I tell them that I don't use the word herx, because in my experience, the word herx actually, to me, denotes that we're having a die-off from whatever organism, whether it's yeast or something else. And that is really not what's happening when we have a flare. When we have a flare, we are stimulating the T cells, but the strength that we're using is too strong. So the stimulation of the T cells is creating the flare. And we know that we have to go weaker in order to get an effective dose. But I do not use that word herx, and I always tell patients just exactly that. I mean, you can call it that if you want to. There's no reason why you can't. But I think that a flare is probably a little bit more accurate for what we're doing.
Okay.
Bill, I see if you asked this question or not, but the question's being asked: if I'm receiving allergy injections regularly for trees, grasses, animals, would those need to be discontinued if they went under LDI?
If you're not crossing over any of the same antigens, so in other words, you know, you listed some environmental antigens there. If there's no crossover, then the answer would be that there would be no problem doing both, as far as I know. Typically, that that question was probably asked the most with LDA, because the typical immunotherapy would be environmental things. And so historically, if a patient wanted to switch to LDA and they were doing traditional immunotherapy, and that would be like with an allergist, so that would be allergy and immunology, or that would be an ENT. And if they wanted to switch over to LDA, then that would be concurrent treatments. That would be 2 treatments being done for the same thing. So I would advise the patient that they should stop that treatment and wait at least 2 weeks before proceeding with LDA. But in the case of LYP, it's not concurrent, it's 2 totally different things. So I don't see any reason, and I could clarify that with global immunotherapy with Dr. Vincent, but I don't see any reason why those treatments couldn't go together. Yeah, I guess I would add one little thing, and I'm smiling because I did traditional desensitization for years, and it works to a degree, but LDI works much better. So I'm just going to throw that in there.
I was waiting for you to say that.
Somebody wants to know, does your practice, do you actually test for Lyme disease and for other things like parasites, or what kind of testing would you do if somebody came to you?
I'll give that to Tara.
So our office is considered a Lyme literate office, and we do test for Lyme and parasites. As far as do you need a positive Lyme test, or to get LYP? Well, I think that our practitioners are really good at making that diagnosis, or I wouldn't say diagnosis, but ascertaining that you have Lyme. We wouldn't want to treat you if you don't, but we also understand that Lyme exists on a spectrum, and it's not a definitive, it's not black and white, positive, negative. We certainly have a different set of criteria than you may find in a conventional doctor's office, but we would certainly have indicators that you had a Lyme infection before we would treat you with LYP. But yes, all of our providers are I think if I remember correctly, last year when they ran, our #1 diagnostic code was Lyme. So, and in my practice as the infusion nurse and doing ozone, the majority of the people that I see are Lyme patients. And then it probably goes to autoimmune, and then it's probably, well, unfortunately right now we're leaning a little heavy on cancer patients.
All right, someone is asking about viral reactivations. Can viral reactivations be treated this way? And they didn't use Epstein-Barr, but Epstein-Barr comes to mind when I see a question like that.
Yep, that's a very common question. And the answer is yes. And then I would need to include that would be diagnosed with a provider. That would not be something that Tara or I would do. Now, when Tara is a nurse practitioner, then she will absolutely be doing that. So, so in the future, I am not, however, a doctor or a nurse practitioner. And so I would not be doing the diagnostics. That patient would already come to me with that diagnosis. And in most cases, our doctors have a very good working knowledge of all the antigens that are available, LYP just being one of them, but all the antigens that are available for LDI. So working with viruses is definitely something that we can do, and that I have done historically all the way back to actually the beginning of my career, and working with like flu, working with shingles, things like that. So absolutely. Tara, do you have anything else that you would add to that?
I don't think so.
Okay.
If someone is asking the name of the hospital you're working in, they may be asking the name of the practice that you're working for.
Right.
St. Paul Health and Wellness. Patty and I work in Mechanicsburg, but we have offices in Mannheim and Paradise.
Another question, can the repeated dosing cause a strain on the immune system, exhausting the response system? This person is asking because they had done years of allergy shots when they were young, and allergy shots can be taxing on the body and has long-term effects.
Well, I would assume from that, or I would infer from that, that they're talking again about traditional desensitization. So I'll put a disclosure out that since I did that treatment for years, I have a strong opinion about it. And the fact of the matter is that traditional desensitization employs very strong aggressive doses. And many times when you look at a vial that has been formulated for a patient, and in traditional desensitization, you do testing, you find results, and then you formulate a vial based upon where they were positive and negative. And you actually start at the point where they are positive and not where they're negative on the skin. So I'm talking on the skin. So they've had a skin response to the strength that you are putting in their vial. And that in and of itself is a more assertive or aggressive approach. So that in many cases, when you look at a vial that's been formulated for a patient, it actually has color to it. Whereas if you look at any of the vials that we use with LDI, they are completely clear, there is no color. And that is a testament to a trace amount that is in them. So that when a patient asks if over time there would be a stress on the immune system, the only way that that would ever happen would be if you were taking the wrong effective dose, if you were taking a dose that was too strong. But I don't see why that would ever be repeated more than once. If a patient has a flare on dose 18, for example, why would we ever repeat that same dose? We would never do that. We would obviously go weaker to that. So we would go to the higher numbers and we would refine it by using the half strengths if we needed to, but we would never continue to dose a strength that has given a patient a flare. So I have not seen over the years any kind of taxing on the immune system. A question that patients ask, and maybe that kind of ties in with what this patient is asking, is, will it do other things to my immune system? I've had that question a lot. I know it sounds kind of general, but the answer is no, it won't. Because why? Because we have the components of LYP in there, the Lyme infections, the co-infection, all different yeast species, and the parasites. There are not other things thrown in for just in case. It's not like when you make a cake and maybe you'll say, I'll throw in a little bit of food coloring to make it look pretty. There is nothing else in there. So we are only going to be targeting T cells with tolerance to those items. We are not going to be doing anything else to the immune system unless we engage with a different antigen. If we engage with a different antigen, then we have to start the process over again. And I'll add something there because I think it's important. With LYP, you see that huge dosing range from 30 to 4C. That's a huge dosing range. Once you get all the half doses mixed in there, you have, I believe there's 40 some vials on my tray. That's a lot to choose from, and that's a lot of potentialities. The other antigens, most of them don't have that broad of a dosing range. Some of them, I started somebody on one just the other day, and the dosing range was 8C to 4C. And I thought, wow, this is going to go fast and it's going to be easy because there's basically only about 5 strengths that we even need to work with. So that's another important factor when we're talking about treating other things besides LYP. They don't have that huge dosing range and they take a lot less time, including foods, chemicals, and environmental.
Okay, this looks like possibly the last question. You may have touched on this, but this person, does this therapy treat mold, Bartonella, and other co-infections?
Did you say mold?
Mold, yeah, mold was number 1, yeah.
So are we talking about LYP Or didn't they say specifically? Are they asking if
said-
LYP treats?
They said mold and Bartonella. Does
Oh,
LYP encompass that?
Bartonella, yes, for sure. As far as mold goes, then my answer would be no. If you're talking about household molds or mildews, things like aspergillus, things like alternaria, which is leaf mold, those things are not contained within LYP. We have yeasts in there, and yeasts are definitely relatives to mold, but they're not the same as mold. So if you want to be treated for mold, then you need the environmental antigen. Absolutely 100% across the board. And I've worked with that a lot. And, you know, there's a lot to be said about mold. People with mold exposure can be very, very ill. So yes, the environmental antigen works very well for that.
Well, this has been great. Well, actually, we got one last question. They want to know, can this treatment be used for animals?
That's a good question. I learned about that the very first time that I attended an LDA conference in 2009, where Dr. Schrader actually was our host, and he talked about it being used for dogs. Absolutely. Now, you have to remember that LDA is mostly injection. So at that time, there was some discussion about how to do that. But if I were going to treat an animal, I would do it carefully, number one. I'm not a veterinarian, so I would want to be in conjunction with a veterinarian. And I don't see why it couldn't be given sublingual. But the only animal I know is dogs. That's the only one I know. And Dr. Schrader mentioned that it was being used for like a eczema-like condition that the dogs have. I don't see why it couldn't be used for any condition that would be diagnosed by the veterinarian as allergic and be done sublingual. But you would definitely need some guidance on what strength you were going to give an animal. So you'd need maybe some cohesion between the providers there.
Okay, Tara, this has been a great presentation. Eric, would you like to wrap us up?
I'm just going to go ahead and wrap us up. Tara, if you could knock your computer off of share screen. There you go. Thank you. Wonderful presentation. Really very good, really tight. Appreciate the time that you put on that. I like the way that you went about providing the information in the background, certainly with the terminology. I know I was getting a lot of text messages from individuals that it really piqued a lot of curiosity. So thanks again. When we put on the Virtual Lyme Impact sessions, what we're looking to do is really bring forth topics and subject matter that really is important to the Lyme community. A lot of our subjects and topics are provided to us by individuals such as yourself that are watching. So if you have a subject or a speaker that you think would be a good presenter or a good topic for us to explore, reach out to us. The emails that you get from us from palyme.org, I'm at 𝗟𝗆@palyme.org, and I can go quickly to a share screen to give you that. So if you do know of a speaker or you know of a topic that you think would be of particular interest, shoot me an email and let me know. We try to gauge the audience. We try to focus group our regional leaders and our support groups to find out what's happening, what questions are they getting. And that's really how we got this information on the low-dose immunotherapy. That's how we got this presentation tonight. So with that, if you know of anyone at any time, feel free to reach out, and that would be fine. So thanks again. Appreciate everybody's attention. Be on the lookout next month. We don't know the subject. We've got a couple of speakers we're trying to tie down, but I'm sure it'll be good. So with that, Tara, Patty, thank you very much. Bill, for all of your help, thanks as well.
Thank
you. Thank you.
Thank you. Thank you. And thanks to everybody.
Bye-bye.